Hi, good morning, everyone. This is Saurabh Agarwal. I am here for inviting 130th CMAAO International Weekly Session. We are live on various social media platforms and our guests joining in from more than 19 countries. We have this almost every week with a different topic, and we try to meet every week, bring information from all countries, try to understand what's going on. And we have been doing this for last 2 years, started by Dr. K.K. Agarwal. Today, we are discussing yet again an important topic in today's scenario, whether it was post-pandemic era or not, but today it has become more relevant. So the topic is mental health and well-being in the post-pandemic era. And to invite our special speaker, I would like to invite Dr. Monica Vasudev from US to introduce the speaker. Over to you, Dr. Monica. Dr. Monica, you're muted.
Thank you, Saurabh, and thank you for allowing me to introduce our illustrious speaker today. Dr. Nimish Desai is a former director, Institute of Human Behavior and Allied Sciences from Delhi. He has made an immense contribution to the development and has helped the Institute of Human Behavior and Allied Sciences to achieve the status of an institute of national importance. He has served on the faculty of two of the best academic institutions, which are the National Institute of Mental Health and Neurosciences, or NIMHANS, in Bangalore for 6 years, and AIMS in Delhi for 10 years. He joined the Institute for Human Behavior and Allied Sciences in 1998 and has served there for 11 years as head Department of Psychiatry and also as medical superintendent of the Institute of Health and Behavioral Allied Sciences for most of these years. He has received the Bharat Swastha Samman by the LIC Z News Award for his outstanding contribution to the field of psychiatry, along with other national awards. It is my pleasure to introduce Dr. Desai to our forum today. Welcome.
Thank you so much. Saurabh?
Yes, please go ahead, Dr.
Sir. Okay. Good morning, good afternoon, good evening, as per your location. It's actually very nice to be here because of the friendship and the bond that many of us in India and across the globe carried for K.K. Agarwal and the lot of friends who manage IGCP and the Art Care Foundation, more importantly, the CMAAO. I have had the good fortune of knowing a bit about CMAAO, but not too much. And so pardon me if I'm not really tuned into everyone's group background. What I'm going to try and do is, as I was saying to Dr. Saurabh Agarwal, not have too long a talk, and certainly not with PowerPoint slides. Possibly 15 or 20 minutes, little over that, if at all. Some initial thoughts and posers to us as senior experienced healthcare providers about mental health. As most of you would know, and one of our colleagues actually has that in the background, after Bukhari Saab. 10th October for many years and decades has been marked as the World Mental Health Day, and the World Federation of Mental Health and WHO that makes out the theme for every World Mental Health Day this year have focused on what I think is interesting, but like many other health slogans, fairly ambitious. And that be one of the things that I should like all of us to talk about. And the theme is make mental health and well-being a priority for all at the global level, or something to that effect. Now, as most of us as medical colleagues and healthcare providers know, psychiatry is a relatively new scientific discipline, less than 100 years, or actually even a little lesser than that. The core of psychiatry that began with mental asylums and mental hospitals, and then came to general hospital psychiatry units, and then came to community-based treatment centers or rehabilitation centers. And by now, in many parts of the world, fortunately forms part of the healthcare service delivery for curative, rehabilitative purposes for sure, possibly for preventive and promotive parts, is still growing. I spent about 40 years in psychiatry and in India, and fortunately got trained in public health. And so I happen to have that concern and perspective. Unfortunately, most medical schools across the globe, and certainly Afro-Asian countries, tended to train medical graduates or medical doctors with very little or zero input about psychiatry or mental health. That fortunately has begun to change, but even the change that happened in the last few decades, sadly, I must recognize, used to be more about professors of psychiatry coming to those large lecture theaters in medical schools, presenting so-called esoteric cases of schizophrenia or bipolar disorder, just to get attention of those young medical students. While schizophrenia is being the torchbearer, so to say, of psychiatry and psychiatric disorders and so mental health, one must recognize that the incidence and the prevalence of schizophrenia, or indeed all severe mental disorders, SMD, what used to be called as psychosis earlier, is not more than 2 or 3%. And this remains similar across the globe because it's largely biologically, genetically determined, as we'll all appreciate. The much more common and disabling, equally disabling, if not more disabling, but much more common, is the group of mental health problems that used to be called as neurosis: depression, anxiety, obsessive compulsive disorder, phobia, of course, leave out substance use disorders and the others. Now, common mental disorders understandably have some genetic biological basis, but has a whole lot of psychological, social, cultural, if not also economic dimension. And so the incidence and the prevalence keep varying across the globe, across continents, urban, rural differences, gender differences, significantly. We'll all understand that it will be higher in urban population, it will be, unfortunately, higher in women as compared to men and stuff like that, and higher in developed countries as compared to the developing or the underdeveloped countries, LMICs. Sadly, the medical education across the globe till date has been, I believe, still lacks emphasis adequately on this one aspect of common mental disorders. For medical doctors to recognize, identify, and be able to treat or refer cases of depression, anxiety, phobia, obsessive compulsive disorder, alcoholism, tobacco, things of that nature. So that's one part. Even more important, it seems to me, is the gap that's just begun to be addressed, is the psychological and social aspects of all medical or surgical conditions. To me, it seems that if you talk about well-being or even mental health, there's a lot more role for understanding and doing what one can at whatever level about the psychological and the psychosocial aspects of medical physical illnesses. I have often, in last at least 30 years, played this friendly game with all group of doctors or healthcare professionals that in this virtual mode might be even easier now or towards the end of the session. I would like to throw a gauntlet and say, name a health condition and I will share with you the psychological or social aspect of that health condition. So essentially what I'm saying, my friends, is that there is virtually no health condition that does not have a psychological or social-cultural dimension. And yet, despite the Flexner report of 1910 in the US and all the reforms that medical education has had, including social behavioral sciences, has kind of remained inadequate or more in theory than in actual practice and learning. I'm starting with that because I do believe, and like many of us do in psychiatry and mental health, regardless of the number of psychiatrists and mental health professionals being inadequate, being adequate, or being more than adequate in different parts of the world, not just for the lack of numbers or the strength that we get in numerically, But for a lot of other reasons, if we in psychiatry and core field of mental health wish to carry the message of mental health to the community, to the populations, it will have to be through our medical colleagues and all healthcare providers. And so I individually tend to take every such opportunity that I have been fortunately provided today to flag these points that I have done till now, and maybe I'll flag a few more, and to see if one can carry some of you or more than some of you to a higher level of involvement and participation in carrying mental health message to the society. So that's first part of my set of remarks. The second, one must briefly recap. There are, like I said in passing, there are significant differences in the prevalence of diagnosable psychiatric or mental health problems across the world. The global figures, some of you will recall, have been 1 in 4. And so like Dr. Saurabh Agarwal and I were kind of chit-chatting before the session started, how many of us around the group here would accept that one might have a mental health problem? And I have this slide that I often use and say, look at 3 friends around you, and if they seem normal, then you know what you should do. But that's about the global figures. Unfortunately, and our friends like Dr. Monica and others might bear this out, but very robust studies by the National Institutes of Health have actually confirmed that the prevalence rate for diagnosable psychiatric disorders in the US of A is nearly 49 to 50%. In different parts of the world, it kind of keeps varying. In Afro-Asian countries, as a cross-section, the rates of mental health problems is much lower, has been at best 10 to 12 or 15%. And so there is this huge variation in the prevalence or the occurrence of diagnosable mental health problems. Of course, not to forget that across the globe, there is a huge mental health gap, service gap. And it's not only in the Afro-Asian region, but across the globe, again, varying degrees of service gap. In Afro-Asia and certainly India and South Asia, as I happen to know a bit better, the treatment gap is nearly 80%. And the treatment gap across the globe for mental health problems would range anywhere between 30 to 40 to 80 or 90% even. If you were to briefly examine what the factors for those treatment gaps are, the commonest response that we would have is stigma. And surely the stigma for mental health problems or seeking mental health help is high, though variable. Systematic field research, including our own in India, has found that that's not necessarily the biggest factor. The largest contributing factors in many countries or many parts of the world is lack of awareness that this is a mental health problem. 2, lack of awareness about how and where to seek help. And so my point, friends, as I have said in the earlier first segment, is that we as psychiatrists, mental health professionals, mental health advocates and activists, and all of you friends in the medical health field need to carry messages to people about reducing the stigma, but also increasing the awareness about this being mental health problems, health conditions which can be treated and prevented like any other, as well as increase access and utilization. And that's where I think all the medical and healthcare colleagues can be such a good help, not just for the profession of mental health, but for the larger population. That's my segment 2. The third segment I have in mind is to briefly address what was highlighted by Dr. Saurabh, and we are all concerned about it towards the end of 2022, is about the COVID-19 pandemic and whether that is leading to a psychiatric or a mental health epidemic. You've all read, I'm sure, in the popular press and media, if not on social media also, as well as in some science literature, but hopefully more contained there, predictions about psychiatric or mental health epidemic following the COVID-19 epidemic. And I want to, in all responsibility and seriousness, put it across to all of you, of course, subject to your own experience and information, is that there isn't really been and there isn't going to be a psychiatric epidemic. So we really need to not create this scare about, psychiatric disorders going high, certainly. What is certainly true, what's been true for last few years and what's likely to be true for next couple of years, if not longer, is softer mental health problems, some of the stress disorders, some of the physical health conditions getting triggered or worsened, and there being universal distress, of course, also contributed to by the economic slowdown and now the apprehended economic recession. But per se, psychiatric disorders in the field epidemiology does not seem to have a great increase. And that's also the evidence from a whole lot of disaster and crisis situations across the globe, including Afro-Asian continents that many of us seem to have studied. That being the case, all the more reason that, let me explain something else that I forgot, pardon me. If at all there is an apparent increase in psychiatric disorders at treatment centers or even in the field social experience that all of us have living in this society, let me put it to you that that is mostly contributed by 2 or 3 major groups. One, people who were on treatment, who have had recurrence or relapse. People who were in the treatment gap of 60 to 80% who are now coming forward. And people who might have temporary stress-related disorders, physical and mental health conditions. And so, to my mind, that's the group of factors that contribute to an apparent increase. Does that mean that we should possibly lay back a little on mental health issues? By no means. Global human community has this potential and time to capitalize on the increased awareness and acceptance of the mental health issues. It seems to many of us that across the globe, but certainly again in Asian or Afro-Asian continent that we are more familiar with, talking about mental health, talking about stress, talking about psychological issues of day-to-day existence has become much more of a day-to-day phenomenon than it ever was. And we need to capitalize on that. We in the field of mental health, with all of you colleagues in the field of health, need to capitalize on that phenomenon to reduce the treatment gap and make sure that more and more people actually reach treatment services. About that, there is no doubt. And so this is as good a time as any, if ever there was, for a mental health emphasis, for strengthening the mental health services, and of course, making sure that mental health services are robust, effective, and cost beneficial. So those challenges we do have, sure, in this immediate post-pandemic era. The last point in that segment, third segment, post-COVID era for communities, for nations, for global humanity is one phenomenon. And we are going through that. One can easily believe now that we are seeing the fag end of the epidemic. But does that mean the same as post-COVID clinical syndromes? To me, sure does not. And many of you must be much more experienced than I am about that. Individual post-COVID syndromes are continuing to occur, are expected to last longer, both physical and mental health issues, and a range of physical and mental health issues. That will perhaps continue for long. And so there is, again, one more opportunity, it seems to me, for all of us in psychiatry and mental health and all other medical surgical disciplines to work together in identifying and managing jointly, appropriately, the long COVID or the post-COVID or whatever else term different professionals or different world regions might use. So that's one more opportunity that we have. Lastly, my fourth segment is going to be about a delicate issue. And again, Dr. Saurabh, and we were kind of touching upon that in our informal chat. And that is about mental health and well-being amongst healthcare providers. Let's face it, across the globe, across fields of endeavor and practice, the concept of care for the carers is fortunately picking up, including care for the healthcare workers. And again, the pandemic kind of provided a very good accelerating emphasis on that. And yet, when it comes to mental health issues, most of us, healthcare providers, medical doctors, other healthcare provider groups, and unfortunately, psychiatrists and mental health professionals, even a bit higher, seem to have a fair amount of issues about accepting mental health problems or seeking help. We as medical doctors aren't celebrated to be the best of the patients when we need help. Certainly psychiatrists and mental health professionals for physical health problems or for mental health problems do not fare even that well. There are issues of perceived omnipotence, the godlike demigod feeling that we carry, whether we are aware or not. The society contributes to that. The stigma about what will my reputation be like if as a physician or as a psychiatrist, I accept a mental health problem, and things of that nature. I am not by any means saying that all of any one of those factors is not relevant. It sure is. From stigma to the apprehension about what it will do to one's reputation and work and all the other factors that we mentioned. But the point, my friends, that I want to make, and I'm sure it's not new in one or the other manner, is this. Like it has been said traditionally, charity has to begin at home. Destigmatization or reduction of stigma will have to begin at home amongst us healthcare providers and definitely amongst us mental health care providers and mental health professionals most. That's not easy, but we need to do that for our own sake, for reasons of removing and reducing the stigma in the society and for spreading the word about mental health. In the end, I'll only say that core psychiatry, detection, identification, and treatment for all those who are willing is at least one doable, conceivable goal. Positive mental health, prevention of mental health issues, and positive mental health, a tad softer, still conceivable. One can, as group of healthcare professionals like CMAAO, have a program on, positive mental health, including identification of psychiatric disorders. But we must recognize, and I really would love to listen to views on that, well-being, as the theme for the Mental Health Day this year seems to emphasize, in a very aspirational intent. Well-being is far beyond only healthcare. We might certainly contribute to that, but well-being is not only a psychological, social, but a political, economic phenomenon. And so we'll have to be that much more careful when we talk about, well-being. Of course, I have my own views that if at all time permits and if we get to those areas, I'd love to talk about, but I'll stop myself from that now. The whole interface between illness and wellness and how this whole idea of absence of illness being a precondition for wellness is really not doing good for human race, I think, at a larger plane. But I just want to flag the issue that like many other health slogans in the last 50 or 100 years, at least 75 or 80 years post-World War II, have been, this slogan for Mental Health Day this year also, I quite recognize, is aspirational, ambitious, if not more. mental health and well-being for all. Make that a global priority. But that's fine. As I've often been told, aspirational expression of intent is not only permissible, is desirable, because that's what motivates groups and agencies to work towards. And my only caution always for myself and whatever groups I work with is to be realistically aware of how far would that aspirational intent be feasible. How do we measure our programs against what we will be able to achieve or not? And so to that extent, the softer areas of positive mental health or well-being aside, but for sure, the science of that we have to say, with all humility but assertion, that so much with the help from basic neurosciences and psychopharmacology and social sciences 3, that today treatment, at least effective treatment for almost all mental health problems is possible. And yet there is a huge treatment gap. So all of us collectively, with you friends in the field of healthcare and medicine, we need to get that benefit to much larger proportion of the world population than we're able to do till now. I see that it's about halfway mark. So Dr. Saurabh and Monica ji and whoever else is managing this, with your permission, I'll stop there. Really wanting to listen to other views as well as possibly have a few discussions, even debates. That should be fine. Thank you so much.
Thank you, everyone. I would like to also introduce Dr. Monica Vasudev, who has few slides over here for presenting.
Oh, okay.
We all know her. She's an allergist and a clinical immunologist from Wisconsin, and she's a fellow from American Academy of Asthma, Allergy and Immunology, and a fellow of American College of Allergy, Asthma and Immunology. Sorry, I'm not well today, so I just lost the screen. Dr. Monica has a few slides before we can open the round for question answers. Dr. Monica, here you are.
Thank you so much, Dr. Desai, for your fantastic introduction to the main concepts of mental health on this Mental Health Day. And I think this is of significant importance of two reasons, two-pronged approach. One is when we're talking to our patients, it doesn't matter what field we're in, their mental health is going to affect our ability to provide care. And then second is our own mental health. We have all gone through something incredibly significant that has changed the way that we have lived our lives, and we have not gone back to what we considered a pre-pandemic normal. If I may, I just put together a few slides as you were speaking, just to kind of re-emphasize some of these important points that you had made. So let me share. Okay, so this is just looking at, you had mentioned about the statistics about the mental health burden in the world, and I'm going to give you some statistics that was provided on a Johns Hopkins website on what the condition is in the US. So mental health disorders account for several of the top causes of disability in established market economies, such as the US, worldwide, and particularly include major depression, which is also known as clinical depression, manic depression, which is also bipolar disorder, schizophrenia, and OCD. And this statistics shows that 26% of Americans 18 and older, or 1 in 4 adults, suffer from a diagnosable mental health disorder in a given year. And many people suffer from more than one mental health disorder at a given time. In particular, depressive illnesses tend to co-occur with substance abuse and anxiety disorders. And I'm sure that we can recognize what is being said here in the patients that we've seen and in the society that we live in. Approximately 9.5% of American adults 18 and older will suffer a depressive illness, major depression, bipolar disorder, or dysthymia each year. Women are nearly twice as likely to suffer from major depression than men. However, men and women are equally likely to develop bipolar disorder. While major depression can occur at any age, the average age of onset is in your mid-20s. With bipolar, it affects 2.6% of Americans who are 18 and older in a given year, with the average age of onset of the first manic episode in their 20s. Most people who commit suicide have a diagnosable mental disorder, most commonly a depressive disorder or a substance abuse disorder. 4 times as many men than women commit suicide. However, women attempt suicide more often than men. The highest suicide rates are found in Caucasian men over 85. However, suicide is the leading cause of death in adolescents in ages 15 to 24. 1% of Americans are affected by schizophrenia. It first appears in men during their late teens or early 20s. That's in the majority of the cases. And in women, it first appears in their 20s or early 30s. 18% of women, or 18% of people age 18 to 54 have anxiety disorder in a given year. And these include panic disorder, OCD, PTSD, generalized anxiety disorder, and phobias such as social phobia, agoraphobia, and specific phobia. I'd like to bring your attention to a few key papers that came up in the field of mental health, especially as it relates to the pandemic. So this was published in The Lancet in November 6th of 2021. It's called The Global Prevalence and Burden of Depressive and Anxiety Disorders in 204 Countries and Territories in 2020. And what you can see here is an infographic summarizing their findings. On the left, you see cases of mental disorders rose sharply during the pandemic, which we have all seen and witnessed. It was major depressive disorder that was felt to be 53.2 million in excess of the baseline of 193 million due to COVID. And in anxiety disorders, you can see an excess of 76.2 million over a baseline of 298 million. Here they showed that the younger people were the hardest hit, and it was due to the additional prevalence was due to COVID-19 by age and major depressive disorder, as well as anxiety disorder. Increases were higher among females than in males. In this graphic, what you can see are the different age groups on the y-axis, as well as the prevalence or the excess of anxiety disorder, major depressive disorder, that were at baseline, and with the additional anxiety disorder and major depressive disorders that you can see here in the center in both males and females. So we all know that the pandemic had a significant impact in the mental health of the world. In this paper, they said that there were 2 specific factors that impacted the presence of mental health disorders. One was the daily SARS-CoV-2 infection rates, and 2, the reduction in human mobility. That increased prevalence of major depression and anxiety disorders. Females were more affected by the pandemic than males, and also were the younger age groups. And I think this is just a very quick summary to show what we had been observing during the pandemic. They also looked at people who were calling into helplines. People who were given these helplines, these phone numbers to call if they had any mental health concerns. And then this was also published as a way to review what had happened during these phone calls. And what you can see here on the right was a daily change in phone calls from time before the pandemic, before the started red line, the onset of the outbreak. And then you could see around like 6 weeks after the onset of the pandemic that the daily call volumes had increased. And what were these calls regarding? So what you see here is in the pre-outbreak share, you had fears, loneliness, suicidality, and addiction. And then you're looking at the post-outbreak change with these specific parameters, and it was the fears and the loneliness that you can see was the highest cause of change in percentage points in terms of the number of calls. You also, Dr. Desai, mentioned about the impact of mental health and the pandemic on our mental health. And so this is another infographic. This was something that was published out of China, and they looked at 1,300 healthcare workers who were in the front lines of the origin of this virus. And what we found was that 50% reported symptoms of depression, 45% reported symptoms of anxiety, 72% distress, 34% had insomnia. And so what they did, or they recommended, was offering resiliency training, looking at the issue with a systematic approach, increasing access to care. And again, Dr. Desai, you were talking about the stigma associated with seeking care, especially in healthcare providers, and changing that shift of culture. And then maybe appointing a point person who is approachable to be able to make it available to people who need it. And I thought this was a really a nice infographic as well, regarding what are things that we can do to address mental health. And that is to improve our satisfaction in our workplace. Is our workplace a place that we really feel is our workplace home? So we felt that 85% of us felt that the pandemic worsened our day-to-day stress levels. 70% reported feeling exhausted and burnt out. And only one in five felt that we felt appreciated. So what did we feel? That if we had medical waste that was appropriately managed, which is interesting, would help our burnout, making sure also that we have access to resources so that we can do our work. I just wanted to supplement what you had said, and I hope you enjoyed those slides.
Thank you, Dr. Monica, for the add-on on the topic, which was more important. We have a comment from Dr. Sanjay on the chat. I feel developing countries will also change the prevalence of the case as in the US due to the increased population, environment, pollution, and disturbing job data coming in future. Any new occurrence of the new pandemic may accelerate the prevalence of the mental disease in the community. So with this comments, we would open the floor for the question answers to the audience. And the question, yes.
Can I give my comment? Saurabh, can you allow me?
Please go ahead.
Okay, thank you very much. First of all, Nimesh ji Desai, thank you very much. We remember the name of very good Prime Minister of one of the good Prime Minister of Morarji Desai. He won the highest award from the Pakistan. Thank you very much. Similarly, very nice talk and very nice, Monica. And thank you. You are always hit the ball around the sixers. Thank you so much. My one suggestion and question to you is that in Pakistan, we saw so many mental disorder during the COVID period. The main was the stigma, the depression, and anxiety. We are hearing from the news and some that after 2 years, a very large, a very serious infection is coming, and that infection will I think, result in a lot of mortality. What message you will send to the healthcare providers in all countries, especially we like developing countries? How can we manage, or how can we prepare ourselves to face that one? Because I am eyewitness. So many people died due to the panic conditions during the COVID, and still there are long COVID people. They are nothing, only they are afraid and anxiety that we have something. So what message, what practical message you will send to the world, especially to the developing worlds, because Dr. Kazi is there. He is now our leader. He can manage, send your message on his platform, so that we should be prepared to face the coming these types of infection. Thank you so much once again. Dr. Desai not hearing.
Monica, can I take that first?
Please go ahead.
Okay, thanks, sir. Thoroughly. Bukhari sir, great question. I'm going to try and again be as concise and to the point as possible. I must admit that in the last 2 years of the epidemic, at our in-person or more virtual meetings in the country or in the region, my generally positive message by persona, by science that I know of disaster mental health and behavior has been toned down a little. I agree with you, and I corrected myself in 2021 that in India, South Asia, Afro-Asia, and the world, during the second wave, which occurred at different points of time in the world, there was much more of a trauma and so immediate post-traumatic disorders, acute stress disorder, as we say, as well as depression. In 2020, I wasn't too keen or willing to believe that. Sure, 2021 played havoc with the psychological experience of a number of things, many of us. And yet, I do believe that without respect to the American science, and I'm so glad you mentioned Kazi साहब CMAAO के अगर की पोजीशन पे हैं तो हमारे ये मैसेज पहुंचा सके. Across the globe and certainly in Afro-Asian developing world that you and I are more concerned about, the resilience at individual level, the family systems and the social support systems actually work much better. But this is a time, pandemic is the time for us to all unite in the world besides recognizing regional differences. Human resilience is larger, certainly in Afro-Asia and South Asia, it's even better. If I may pontificate, possibly seemingly a little, what this epidemic has taught us is these few things. Human race. One, health is important. In that, mental health and behavior is important. Two, till now, many of us in the field of public health and behavioral sciences were keen to get across the message that individual health depends on your behavior. Your health status, my health status, Monica's health status will depend on what's our lifestyle and behavior. Now it has gone a step further. Communities and societies' health status will depend on how the collective behavior is. Right? Because of the transmission of infection, because of the other effects. We need to get that message across more strongly to individuals, communities, and nations, and say lifestyle and behavior being appropriate, health appropriate, is the most important thing that we need to do, even if there is going to be, God forbid, another severe, strain of the virus. Three, I really believe that what this epidemic has taught, and many of you are actually more experienced and directly connected, I believe, science can meet the urgent needs of healthcare as effectively as it used to earlier in a long-term care. See, vaccine development, treatment innovations used to have a lag period of 5 or 10 or 20 years. Human race and some parts of the world particularly responded so promptly that time lag from innovation to implementation actually came shorter. And although we lost many lives and a lot of millions of people and families went through trauma, one can only imagine if what the scene would have been if the medical and basic science had not responded as well as it did. See, I do believe that we sometimes tend to forget in the experience of trauma, the positive aspect of what science has done. So the positive aspect of science, the contribution of healthcare field in actual ground implementation is something that should give all of us as human beings, and certainly in some parts of the world, more confidence to face future challenges if there are. Allow me this, sir, PTSD particularly. I really do believe, and I mentioned the American science and with genuinely due respect, is PTSD to my, and I have trained in public health. I've examined this fair bit besides our fieldwork in India. PTSD, while a valid clinical entity across the globe, is in the American setting largely a political economic phenomenon. Let me give an example. After the Gujarat earthquake of 2001, that most of you might recall, at least when I mentioned, we not only got into the field very early for service delivery, but we did a 8 or 9 year follow-up up to 2010 of 35,000 population. And no long-term PTSD, my friends. There is by now, I think, besides our own work and my own work and conviction, there is a fair bit of, if not strong evidence to believe that PTSD is a strongly socio-culturally relative concept.
Sure, sure.
Our individuals and our communities manage post-traumatic effects very, very differently and better. So we don't need to be too scared of PTSD. Acute stress problems, yes, sir, including worsening of healthcare. Monica, please.
Thank you, Dr. Monica, thank you. You also shared the two links. And I am always blessed that before any of my talk in Pakistan, your talk helped me in preparing the good talk. Thank you very much. You shared the two links, very beautiful links you have shared.
Thank you very much.
Hi, can
I wanted to highlight the second link that I had posted, and I'm just going to share my screen again, just so you can see what this is. And so what you see here is a document from the American Medical Associations, what physicians can do to address their mental and behavioral health care needs within their practices. And I'm going to scroll down here. Feel free to feel your feelings, employ coping strategies, perform regular check-ins, take breaks from the news and social media. I'm sure we've all been overwhelmed by the negative information in the news. There's a lot going on that make us all feel very sad about what's happening. But I want to draw your attention about taking care of your staff. Whenever we provide any sort of healthcare, we always do it in a team. It's not just the physician, it's the physician and the extenders of what we do, we do it together. And if all of us provide a very healthy and happy environment within our staff, it'll feed off of one another. If the people that we are working with are providing that support, then we equally can provide that support for them as well. And it's important that whenever misunderstandings or issues arise, that we call it out right away, we deal with it right away, and we don't let it fester. If we then take care of ourselves, we then have a much better chance of taking care of our patients. And that is what we all have done and what we will continue to do, because this is the oath that we took as we became physicians. And so for us to be able to take care of our patients, we must take care of ourselves, so we're in a position to be able to identify what their needs are and to use the best possible resources that we have. So I just wanted to share that.
Can I quickly say, Sanjay sir, that I don't know if our good friend Dr. Vijay Agarwal is here, but the CMAAO, Confederation of Accredited Health Organizations in India, which is about 500 or more healthcare organizations across private, corporate, and public sector, has initiated a program on the lines of what Dr. Monica just now mentioned. And I was lucky to be part of it. In fact, if Dr. Vijay Agarwal was here today, I would have tendered a public apology on this platform because I have been a little tardy. But the Indian Organization of Accredited Healthcare Organizations is actually working on the lines that Dr. Monica has brought out so well. You know, care for the carers in the post-pandemic era. Dr. Sanjay has also made this very good point in the chat about how effect of COVID pandemic is in corporate world, and it has recognized the occupational health consultants. I couldn't agree more. This is also the time to capitalize on occupational health, like I think Dr. Monica also said. Kazi साहब कुछ कह रहे हैं सर?
Okay, thank you very much. This is Kazi Wasir. And first of all, I would like to thank Dr. Desai for a very wonderful talk he's given. And of course, Monica, as usual, updated us with the vital data from around the world. I would like to share some of the facts which I was reading yesterday. I was reading the WHO postings yesterday, and especially on the occasion of this Mental Health Day. According to WHO, an estimated 12 billion work days are lost annually due to depression and anxiety, costing the global economy nearly $1 trillion, a huge amount. Then two new publications which aim to address this issue are published yesterday. WHO guidelines on mental health at work and a derivative WHO and ILO policy brief. WHO's global guidelines on mental health at work recommend actions to tackle risk to mental health, such as heavy workloads, negative behaviors, and other factors that create distress at work. For the first time, WHO recommends manager training to build their capacity to prevent stressful work environments and respond to workers in distress. WHO's World Mental Health Report, which was published in June 2022, showed that 1 billion people living with a mental health disorder in 2019. 15% of working age adults experience mental disorder. Work amplifies wider social issues that negatively affect mental health, including discrimination and inequality. Bullying and psychological violence, also known as mobbing, is a key complaint of workplace harassment that has a negative impact on mental health. Yet, discussing or disclosing mental health remains a taboo in work settings globally. The guidelines also recommend better ways to accommodate the needs of workers with mental health conditions, propose interventions that support their return to work, and for those with severe mental health conditions, provide interventions that facilitate entry into paid employment. Importantly, the guidelines call for interventions aimed at the protection of health, humanitarian, and emergency workers. COVID-19 triggered 25% increase in general anxiety and depression worldwide, exposing how unprepared governments were for its impact on mental health and revealing a chronic global shortage of mental health resources. In 2020, governments worldwide spent on an average of just 2% of health budgets on mental health, with lower middle income countries investing less than 1%. So, I mean, these are the guidelines which WHO is constantly putting up. And I think it's a very important topic, and everybody should, put their head down now to, like the slogan says, that make mental health for all as a global priority. Thank you, Dr. Desai and Monica, and thank you, Saurabh, and thank you,
Thank you,
everyone.
President, for your wonderful comments. And can we have quickly one question more, and then we will wrap up the session, if there is any question?
I think Sajad Saab.
Yes.
Dr. Sajad has.
Yeah. Can I?
Yes,
Saurabh, I just raised the hand just to say something, but Dr. Qazi Wasit has already said. I just add and inform the participant that in the recent CMAAO meeting in Karachi, the theme of the conference, there is a recommendation. A very well document is prepared, which is being posted in the CMAAO website. So that will help everybody. I request to everybody to go and see the recommendation which is being prepared by the CMAAO in the last meeting. It will be very helpful, particularly today's topic. And lastly, I must say and congratulate and thanks the Dr. Desai for presenting the excellent presentation as always he is doing. Thank you very much, Dr. Desai. Thank you.
Thank you.
Can I just say two quick things, sir? One is our friends from Pakistan must know, but I must share that our common friend from Pakistan, Afzal Javed, is currently the president of the World Psychiatric Association. And so CMAAO might want to connect with Afzal, who is a personal friend also, to take this idea forward. And the second, sir, is that on the lines that Dr. Monica was showing so well, if at all CMAAO would like to consider, framing and issuing guidelines for mental health care and psychological well-being for healthcare providers, like Dr. Vijay Agarwal is doing for CMAAO.
Thank you for your feedback. We will look into that matter. Dr. Chong, are you there to close up the meeting?
Yes, I'm here. Hi.
Hi, Dr. Chong.
Hi, everyone. Hi, President. Hi, Dr. Sajat.
Hello,
Well, good to see you.
Hi, Dr. Desai. Thank you for that beautiful presentation.
Morning, sir. Morning, afternoon.
Yes, thank you for the beautiful presentation. And sorry I came in a bit late. And always a pleasure to see everybody here. And this World Mental Health Day is really quite important. I think mental health is really a neglected child of medicine everywhere. In Singapore, for example, one of our permanent secretaries of Ministry of Health has said that we will be lacking psychiatrists, psychiatric beds, psychologists, and psychiatric nurses for the next 50 years in Singapore. So yeah, so all this is really quite rings a bell and strikes a chord with all of us. A long neglected child. My own boy is in Monash in Melbourne doing psychiatry training. So I have some vested interest in this. So, but nevertheless, it is something that we should continue to push and to remind our constituencies and of course our governments that mental health is really, really one of the big frontiers that we have yet to make a dent into. Dr. Sajat, you have something to say? His hand was raised. No. All right. Otherwise, thank you very much, everyone. Yeah. Thank you very much, everyone, for this wonderful meeting. And it's good to see everybody again after our recent trip to Pakistan and Karachi. Dr. Bukhari, good to see you.
Thank you. Thank you very much.
Thank you.
Any parting words from our president?
Thank you.
Saurabhji, thank you.
It was wonderful to meet you in person here in Karachi. It was wonderful meeting. We love you. Love you all. And we missed those who could not make it.
Desai साहब हम आपको पाकिस्तान एक दफा देखना चाहते हैं. Welcome.
I was going to say, भाई एक बार लाहौर आया हुआ हूँ मैं. I have been to Lahore once.
I live in Lahore. I'm sitting in Lahore.
Lahore is so good. और ये meeting हम miss कर गए अगली बार. Inshallah.
So
Okay.
with this note, thank you everyone. We will
Thank
wind
you,
up
sir,
this meeting.
Saurabhji. And Monica, great meeting you. I'll connect.